Good afternoon. Good afternoon to my fellow commissioners and to all of those tuning in on the live stream. Welcome. We'll begin today's meeting with a recap and discussion of the 2025 healthcare cost trends hearings, which we just held last month. And then our executive director, David Seltz, will walk through a number of healthcare cost containment strategies and policy actions that have been taken this year at the state level across the country, before we turn to our discussion of the HPC's healthcare cost trends report and specifically the accompanying 2025 policy recommendations. We'll conclude today's public meeting with agency updates, as always, in the executive director's report. And following that, the commissioners will vote to enter a confidential executive session. We will not return to the public meeting after the executive session today. Our first order of business is to vote on the meeting minutes from our last board meeting, which was in October 2025. Could I have a motion to vote on the minutes?
So moved.
Second?
Second.
Are there any amendments? All in favor, say aye.
Aye.
Any opposed? Yes,
May I abstain from the vote, please?
sure.
I'd like to set the meeting abstain as well.
Thank you. Sure. Now I'll turn it over to David Seltz to recap the healthcare cost trends hearing.
Great. Good afternoon, commissioners. Great to see you all. And thank you to you and to the members of the public for tuning in today. We have a great agenda here for our final meeting of calendar year 2025. First, we wanted to begin with a little bit of a recap and a further opportunity for discussion from our 2025 cost trends hearing. If you can believe it, it was just 5 weeks ago. To me, it feels much longer ago than that. But it was really an incredible event. As I said at the end of the cost trends hearing, thank you so much, commissioners, for your leadership and for your questioning. As I'm sure you heard, as I did, from many who attended and who were impressed with the thoughtfulness of the discussion, the questions of the panelists who participated and who provided testimony to the commission. It is truly a unique experience and a unique opportunity to have this annual check-in with the leadership of our healthcare community, as well as those individuals who have been uniquely impacted by some of the strains and impacts of our healthcare system. So for my portion of this conversation, I really just wanted to highlight a few different quotes and themes that came out of the cost trends hearing, but really then we'll turn it over to you, commissioners, to share further insights, takeaways, and particularly any action items you think that the HPC should in the work ahead. This will help inform our next conversation, which will be around our 2025 cost trends report and the recommendations, which will help frame up our work for the next year. So first, we were so pleased to be able to kick off the day with remarks from our Attorney General. She, I think, really encapsulated many of the themes right from the beginning in terms of the challenges facing both Massachusetts and the country, focusing in on the challenges of affordability and the challenges of coverage and access facing some of the federal policy changes. This quote here, "Business as usual is not working. Patients as a result are suffering." I think we heard a flavor or a twist on the phrase "business as usual is not working" repeatedly throughout the day from many different types of panelists. She also shared, I think, a very powerful in terms of her commitment to fighting back on behalf of the residents of Massachusetts. And again, I think a theme that came through multiple times during the day about what a unique place Massachusetts is in terms of its capacity to take on these challenges. Our first panel of the day, I think, was I personally always find very powerful. This was a panel of clinician voices, small business voices, community voices, representing a wide range of different perspectives, all of whom I think really shared perspectives about how the healthcare system is straining at this current moment. We heard from Dr. Elena Stinson, who's an emergency medicine physician, who was sharing what she's seeing each day in the ER in terms of the acuity of the patients who are coming in, patients who are coming into the ED who are not able to get a primary care doctor's visit and who are as a result coming into the emergency room visit. We heard from Neil Abramson, who is a small business owner, and his challenges with being able to continue to provide affordable coverage to his small business employees. And other members of the different aspects of the community, Catherine Gergen Barrett, who talked about primary care clinicians and the burnout. I think all putting a really kind of human and personal face on the challenges from a number of different perspectives. We had an excellent presentation from Audrey Shelto, who brought some data and evidence to our conversation and really focused on the coverage and access challenges that this Commonwealth will be facing in the years to come, and really highlighted some of the difficult decisions that will be ahead of us as we consider some of the potential federal policy changes and what that may mean for coverage, both for the Medicaid program, but also for individuals who are purchasing through the connector and through the marketplace. This led to a panel that we had with different state policy leaders in talking about how the state is going to respond. Here too, I think there was a theme of how Massachusetts is uniquely poised and has a history of stepping up in these moments of crisis and challenge, drawing on examples from the recent past, where Amy Rosenthal at Healthcare for All had talked about efforts in the past to maintain coverage for individuals who had lost coverage during Medicaid redetermination. Here a quote sharing some of the stressors that she was seeing in the system. Also heard, I think, a great testimony from Mike Levine, who talked about some of the very concrete steps the state is taking to plan for and prepare for potential losses in coverage. In the afternoon, we had a great little mini panel from our colleagues at UMass and Mass General Brigham, talking about some of the innovations at the Hospital at Home program. I would note at the time and still today, this program, at the time this program was expired, this program has now been temporarily reauthorized by the federal government. I think that temporary reauthorization expires at the end of January. But there have been some efforts in the federal government to make a much longer extension of that. So my understanding is the House of Representatives has passed a 5-year extension of the authorization, and that effort is currently before the U.S. Senate. I presented some data and some facts around some of the premium trends that we're seeing here, specifically in Massachusetts, and some of the acceleration specifically in the premium trends and cost trends, and highlighted some of the troubling affordability trends that we're seeing specifically here. And then finally, in our last two panels, we focused, our panel 4 was on our pharmaceutical market trends, and we had a wide range of different perspectives from different parts of the pharmaceutical ecosystem, kind of a wide-ranging discussion. Here is a quote that we pulled that was, I think, reflecting a conversation that we were having about GLP-1s, and the conversation talking about the kind of cost effectiveness of these drugs and the determination that they were cost effective. But even though that they're cost effective, that doesn't mean that they're necessarily affordable. And what does that mean for affordability in the context of being able to have these types of drugs that are deemed to have significant potential positive impacts, and how we might have to change our payment systems and structures to be able to make these innovations accessible. And then finally, a panel with, I think, healthcare leaders, I think, again, returning to some themes around the need for collaborative action, the need for a change from the status quo. And I pulled the quote here from Dr. Kevin Tabb, urging us to get beyond magical thinking and to confront some of the structural challenges and systemic challenges in our healthcare system if we're going to be able to hold true to our values in the future. So those are some quotes and themes that I pulled from the day. but I will turn it over to you, Madam Chair, to facilitate a conversation, and would love to hear what struck commissioners and how we might take this day and help inform our work moving forward.
Thank you. Comments and thoughts from commissioners? As you've reflected on both David's presentation today, but also your thoughts since the hearing?
I have some thoughts. Thank you. So there was really one theme that kind of sat with me after the cost trends hearing, which I think has been an issue and a challenge that we're facing today that was raised, I think, fewer times than I would have expected. And I'm thinking back on Amy Rosenthal's testimony on behalf of Healthcare for All, where she brought up the fact that on their hotline that they were receiving fewer calls from individuals for whom English was not their primary language, and that it appeared to be a pretty dramatic drop, which is signaling that perhaps these individuals are not seeking care, they're not seeking help. And clearly this is coming from draconian immigration policies from the federal level. And we already have evidence from 2017 during sort of the first Trump presidency, where a Massachusetts-based research team did research on missed appointments and no-shows among people for whom English wasn't their first language. So folks who spoke Spanish, Haitian Creole, and Portuguese. And they found that there was a significant drop in these individuals showing up for necessary appointments. This clearly compromises patient health in more ways than one, but also it impacts the revenues that our safety net hospitals and our safety net providers receive. So there's more than one impact here. And I think as a health system that we ought to think through and confront ways to really ensure that healthcare providers and that, places of care remain safe spaces. And I think that was a point that Amy Rosenthal aimed to emphasize. And I'd like us to continue to think through that theme today and as we strategize ways to anticipate these coming Medicaid cuts. The other piece that I've been thinking through is the segment on hospital at home, and definitely a rather impressive program that allows these hospitals and systems to reach patients who might not otherwise make it to the hospital. I was struck by the comment or the observation that the demographics of groups that were seen in hospital versus those who were seen at home appeared to be the same or appeared to be equal. And, I just want to remind folks that equality is not the same as equity. And that, if we're really kind of looking across various metrics, there should be ways that the hospital at home population, I would say, should look quite different from the in-hospital population on, factors like access to a vehicle, disability, et cetera. And I would like us to encourage us to think of ways that these hospital at home programs can track how well they're reaching these hard to reach populations. And I think that would certainly help it along the way of being pro-equity. So those were my main reflections from a few weeks ago.
Thank you. And just to make sure I understand you about the hospital at home, meaning that because some patients and their family may have more barriers to getting to a hospital, you would have thought that the hospital at home programs have been able to address some of that challenge and that the numbers would have been higher for people with lack of access to transportation.
Right. And I don't think those measures are tracked by these programs. I'm not sure if they are, but if they're not, I think that we ought to be tracking them.
Thank you. Commissioner Cohen?
So I've sat through many cost trends hearings, and I have to say, I thought this was the most provocative. For me, I think I mean, the way it was organized in the panels, obviously, we heard from lots of different participants and who really all basically agreed that the system is at an interesting inflection point around affordability, around access, and obviously, what people are receiving in the way of healthcare. It's interesting. I also received more feedback than I've ever received from the other cost trends hearings I've participated in. Lots of texts, lots of calls. Folks saying, yes, it's great that we all live in Massachusetts, but what's the answer? And I think for me, and you still have it up, Kevin Tabb's quote is really what we have to consider. What are the solutions that we need to really dig down and work on to try to first and foremost deal with the affordability question? And his point, this is an $80 billion system that is probably limited in growth given everything that's happening both in the federal government and the state government and where we are with payers and providers. So I think, the report that we're going to approve, I hope, has some very clear recommendations. And I think that's really the agenda for us moving forward.
Commissioner Weidman.
Yeah, thanks. So, unlike the previous commissioner, this was my first cost trends hearing. So I have a more limited perspective, but the title of it, cost trends hearing, what I was struck by and impressed from all of the stakeholders was there's a focus on cost. And I agree with the point previously made that there seems to be a recognition on the inflection point and perhaps difficult choices that need to be taken. And what I saw and wasn't fully expecting was there was a beginning. And I mean this genuinely, which is the beginning of what are the outcomes that we're getting for these investments in different areas. Because my fear coming in was cost trends, you can get numbers. But when you make difficult choices, you really want to understand what do you get for the different investments that you're making so you can make appropriate choices with policies that will keep the things you want and focus on the areas that can be improved. And while it wasn't an outcomes trend hearing, and perhaps that's something for the future, my hope is that it is moving in that direction of where are we seeing costs, where are we seeing the efficacy, where are we seeing what we want to see come from these things so we can separate the important areas from the areas for improvement.
Commissioner Erickson.
So I've reflected on two themes, one of which was access. It's not the access trends hearing either, but that federal policy changes are just removing so many resources from our system, and that health and the connector are really on the front lines of trying to minimize some of the damage to the Commonwealth from that reduction in resources. So access definitely was there, even though it wasn't the access trends hearing. And then costs, there's a lot that's on our agenda already, like talking about private equity, talking about PBMs, and there were things I didn't hear as much about that I thought would be an important part of that conversation. So market signals being both valuable but limited, right? That the market can be really helpful in telling us what patients are wanting, what employers and people are demanding from their healthcare system. But then there's parts of the healthcare system where those market signals aren't working well, where there isn't competition and where patients can't shop. And so that's something that we could be attentive to. And thinking about, as part of a cost reduction agenda, ways to increase competition, to lower prices. So some of that is, already in the law, things like enforcing some of the anti-steering, anti-tiering contract prohibitions that are already out there that help payers negotiate for better prices. And then other things could be things like expanding the supply, licensing, the Interstate Medical Licensing Compact, the thinking about telehealth and allowing people to come in. We've suspended a lot of telehealth regulations during the pandemic. That was a big shift in supply and availability of providers. We have a provider problem for primary care, and that should be something we're thinking about that could help drive down prices. And then on the other side, thinking about innovative contracting for pharmaceuticals, ways in which we could think about exploring, say, subscription products for like Louisiana did with hepatitis C and Sovaldi, ways in which we could pay a fixed payment and get a lot of access, more access than we currently have now. So those are things that I'm thinking about, of using market signals, increasing competition to push those prices down so that people get what they want, but at lower prices.
The comments, Commissioner Wilmot?
Yeah, so I think I've been to all the cost trends hearings, but never on the dais. It was my first time up there, and that I was struck. I thought it was excellent, and I think over the years, particularly the provider and the payer communities in Massachusetts have come to these hearings with maybe a different mindset, maybe a more cooperative mindset, maybe an understanding that there are compromises that need to be made in order to keep moving the system forward. So I think that's great. And I think we saw some great panels of those folks, and the state as well. The state continues to step up their participation. What I was a little disappointed with was panel 4 on the pharmaceutical market trends. I was struck by the fact that 2 of the representatives were out-of-state folks. That Eli Lilly is an Indiana company. We have big drug companies in Massachusetts, and I didn't see them on the panel. I could be misremembering, but the way I'm remembering it and reflecting on it was I didn't really hear a commitment from the local players from Massachusetts pharmaceutical industry to participate in the process, to join the rest of the stakeholders in helping to drive down costs. I felt like we saw what we've often seen, which is a little bit of finger pointing between the PBMs and the manufacturers and the and other players, but not a lot of solutions put forth on the table. So I'm hopeful that our new Office of Pharmaceutical Policy Analysis, is that what it's called, OPA, will start to move things in a better direction for when we're and that we'll be in a better place to really sort of try to hold the Massachusetts pharmaceutical industry a little bit more responsible and try to get them a little bit more involved in this process. I'm sure some of our new commissioners might help with that as well. So I just wanted to say that other, besides that, I thought it was a great hearing. I just felt I think there is more we can do in that area, and I hope that's something that we improve on, over the course of the next year.
Commissioner Wolf?
Thank you. I'm kind of aligned with Commissioner Wilmoth, but I have a little different. I was optimistic by the pharma panel, and the reason is because you had a tremendous compassionate leader from one of our payers in the Commonwealth that wants to be responsive to his consumers, and then 2 seats down, you had a pharma representative who can do better on price and was transparent, would provide a necessary and life-changing therapy for less cost. And the optimism for me was I thought it was a message around administrative simplification, because you had the PBM sitting between them, not allowing them to talk to each other. And if they could have talked to each other, I think they would have done a deal by the end of the afternoon. And this person that wants to be responsive to their patients would have been able to provide a drug at a cost that is more affordable. My only other observation, which again, is a positive, let's assume that the parties present let's accept the premise that the patients aren't getting access to care that they need, and they're telling a story that is incredibly heartbreaking at times. That the providers are doing what they can and trying to keep service lines open. That the payers are responsive to consumers that are seeing their costs go up in a rate that becomes unaffordable to businesses and to individuals in the Commonwealth. And a pharma company that wants to continue to produce life-saving therapies, and some of them produce here in Massachusetts. If all those 4 premises are true, then I think we may have to look at the more global picture. How are we delivering the care? Where are we delivering it? To whom are we delivering it? How much are we delivering it? And it almost is a call, if we accept the premise that what we heard was factually accurate for the people presenting to us, then we need to focus on the delivery system transformation. And maybe a difficult time with certain cuts that may be coming our way is exactly the time to be bold, as the Attorney General suggested.
Commissioner Cotterill?
Yes, so this was my first, and I found it very informative. But what I walked away with was definitely concern for cost, concern for access. And just to dovetail on something that Commissioner Walsh said, is that what I heard was a call for action. That what's been, we're at a critical level here, and, now is the time to make change. And I think that there were lots of different people in the room for different sectors. And so I think as we look at the recommendations, how do we look at bringing people together collectively? Because you can't have everyone working at silos to address the transformation and the recommendations. So how do we think about, from a policy point of view, really bringing everyone together collectively to address the issues? Because people are saying, the status quo is not working. We really need to act now, but it is going to take a collective wisdom from all parties and not everyone. The insurance company thinking about what's going to work for them, the hospitals thinking about what's going to work for them. And so we have to really think about what a collective solution looks like.
Yeah, so, I think given all the comments by commissioners, if we're seeing the cost trends hearing as a way of annually measuring the pH balance in our state around what's happening with cost, access, and what's ahead, I think what we all heard was that for really the first time that I can remember, there was this common commitment to change, meaning it is broken, so we have to fix it. And that there was a need for the convening that that Commissioner Cotterill was describing, that everyone was feeling that they were ready for that convening discussion. And certainly the HPC wants to be a part of that, including our putting forward policy recommendations that are one lens onto, some of the areas that could be explored. I think I was optimistic because like Commissioner Walsh and Commissioner Cohen, I was hearing some invitations from many of the panelists for our involvement, including our role around pharmacy and health planning, and the openness to the need for that kind of work on our part. And what I've heard since the hearings was some expression of a belief that the HPC could play a very positive role in that. So I think there was the openness at the hearing to change and to convening, and then I think also underscoring the need for the HPC's work in health planning and pharmacy. So a good jumping off point for our discussion around policy.
Sure.
Comment?
Thank you, Chair DeVoe. That's a good segue into what we wanted to reflect on. First, wanted to take an opportunity to commend Director Seltz and the whole staff for a great job at the hearing. Saying that because I'm an alum, but another chance to underscore a great job. Commissioner Caljo, I think he said that day, he also has been at every cost trends hearing. This was the first, of course, on the board. So he has witnessed them all, and he participated with, and we watched with interest that day at the hearing. And I think I've heard it twice already, but in terms of a core takeaway from our perspective, would underscore that we are at an inflection point. I think that's the key term we've heard so far with respect to the costs that are hitting the healthcare system in Massachusetts. HPC has a lot of excellent look back data, including, looking at THCE as it compares to the benchmark. But at the Division of Insurance, we have a bit of a window into the future as we see premium data projected for the year ahead. And the storm clouds are darker than ever, if you will, with respect to system costs. And meaningful reform is needed. And that is important to consumer protection, which means protecting patients. And as has been discussed, if patients cannot get the care they need because they cannot afford it because of premiums or cost sharing, we're not doing our job. But it will require, however, meaningful multi-stakeholder discussion and approach that we need to be honest about. And as has been mentioned, there are difficult discussions we need to have in the Commonwealth and a critical time sensitivity to having them. And HPC is an important player in those discussions, both with respect to how it can and should use the authority it currently has, and also with respect to thinking about how to build the commission for the future with respect to those critical goals around cost and affordability.
Thank you. Other thoughts? Comments from commissioners?
I think on a few of the comments made, the one thing that it was reminded to me when we went through this, as we went through the comments, was we had stakeholders who hadn't shown up for this type of hearing. To me, the discourse, I was encouraged in a very positive way. And I say that because I think every stakeholder who was on the dais that day and in the panels, they came with an assumption of good intent. And that's not something we often hear in different states. At the federal government level, there's an assumption that that isn't true. But what impressed me, when you hear the word hearing and when you bring these types of stakeholders together and you have different individuals with different perspectives on the stage, sometimes I think people expect something different. And I was impressed that Massachusetts, in this case, led with an environment in which people assumed good intent at the starting point. And I would say that the hearings, there's a lot of work to be done, but I would just say, for my first one, I was impressed. And having seen other state organizations operate in different ways, I was impressed that there was an assumption of good intent. And I think then you have the environment that can catalyze something that can be unique.
Well said, thank you. With that as a jumping off point, let's move to the discussion of this year's healthcare cost trends report.
Thank you, commissioners. So that's a perfect segue to move us right into the discussion today of our cost trends report. I did have one additional slide in this section, just summarizing some of the public testimony that we received from the cost trends report. I'm going to move past that. To begin this conversation, I first just wanted to take us a little bit back in time and just share, again, a little bit of a reminder of what our policy recommendations were last year to inform a little bit about a little bit of the different approach that we're recommending this year with the policy recommendations. So you can see on this slide 13, just a summary of the recommendations that we included in last year's cost trends report, which were really informed at the time by the bankruptcy and dissolution of Steward Healthcare and the tremendous toll that that had on our healthcare system, and the opportunity that the HPC and others had recognized to make some real improvements to our market oversight. And so we had recommended very specific recommendations around changes to our material change oversight process, so that certain types of transactions involving private equity would be noticed to us for the first time for public review, very specific recommendations around changing of financial thresholds in our registration of provider organizations, such to be able to have greater insight into different types of provider organizations. And a very specific recommendation that we should revitalize health planning, should undertake and have the ability to do both focused assessments of need, supply, and distribution, but also to be able to conduct and do a statewide health plan for the first time in decades, to understand the distribution of our services and facilities and workforce, and how that aligns or does not align with the needs of our patients and communities and residents, and to make policy recommendations to have that alignment drive our policymaking moving forward. We also had some recommendations around addressing some of our longstanding recommendations on price variation and longstanding recommendations on focus around primary care, healthcare workforce, administrative complexity, and pharmaceutical manufacturer and pharmacy benefit manager transparency. So we were very pleased to see this year that there was tremendous action by the legislature. And so we issued this report, I think, last November. And in January, at the beginning of this year, the legislature took action and passed two significant laws that are the most significant in terms of changing our healthcare cost containment approach since 2012, when the HPC and the benchmark were first established. And these laws include many, many provisions that were both reflective of the recommendations that we made last year, as well as past recommendations that we had made. So again, specifically, these laws address the very specific recommendations that we had around strengthening market oversight, specifically of private equity. It addressed the very specific recommendations we had made in the past around the need for greater oversight and transparency of the PBMs and manufacturers, and established the new Office of Pharmaceutical Policy and Analysis within the Health Policy Commission. The laws established this new Office of Health Resource Planning within the Health Policy Commission. It established a new primary care task force, which I'm honored to co-chair with Secretary Mahania. Again, focusing on one of the core areas that we had recommended. So this was, I think, a really tremendous step forward in terms of our recommendations and the legislative action that came from it. And so as we were thinking about preparing recommendations for this year's report and this year's cycle, at the last meeting we had talked, and many of you had encouraged perhaps a little bit of a different approach in thinking about what are the most important themes, what are the most important organizing principles that we want to pull together, and to really have a more focused approach to the recommendations for this particular year, and not maybe have, to excuse the term, a laundry list of very specific policy proposals, recognizing that these laws had just passed. And those recommendations that we heard at the last meeting, I think dovetailed so incredibly nicely with what we heard at the cost trends hearing, where we did hear a return to some of the same thematic principles and goals that you all have just laid out for us today. And so as we put together the proposed recommendations that will be part of the cost trends report that is before your consideration today, we really tried to think about a narrative and a call to action. And so commissioners, the full text of these recommendations is included in your binders under the tab cost trends report policy recommendations. So those are there for your reference. The text that you'll see on these slides is an abbreviated version, but the text that's in the report I think is critical. Every word in here was painstakingly thought through, but I didn't want to just put all of the words on a slide. So first, in terms of kind of the narrative and the context, we wanted to start with this history. And this is a theme that we heard at this cost trends hearing, and that I think is so important to recognize and understand, that we do have a history in Massachusetts of being able to come together in moments of crisis and being able to identify collective action and collective solutions, and working together across all of the different silos that Commissioner Cotterill, you mentioned earlier. And putting aside some of the particular interests of each one of those groups in the service of a greater good. And we've seen this in the passage of significant legislation in the past that had big societal goals around ensuring that everyone had access to health insurance, to what we saw in terms of the coordinated response across so many different actors during the COVID-19 pandemic. Governor Baker often would cite studies that we had one of the most successful COVID-19 pandemic responses of any state in the country. I think second only to Hawaii, he would say, and they were an island. And that is really a reflection of the coordination that happened from a public and a private standpoint of our entire healthcare system, from communities to hospitals to community health centers to the state, all working together. And we saw that again last year, when there was, a real moment in time where we could have lost multiple hospitals across the Commonwealth to bankruptcy and closure. But for, again, I think a very rapid and urgent and needed response from the state and from, healthcare organizations and communities to step up and say, we have to make sure that we're protecting access in the face of the Steward bankruptcy. So we have this history that we can draw on. We are now confronting, as you have all said here today and this morning, another inflection point. And in this recommendation, we're really highlighting that inflection point around endangering two of our state health policy goals of the past 20 years of affordability and access. Here on this slide, we highlight some of the stats and figures and dynamics that are endangering and threatening those core policy goals. We see that in the trends in premiums. We see this in the known trends in residents avoiding needing care, incurring medical debt. We know that unless there is federal action, that hundreds of thousands of residents that purchase through the connector will see even higher rates of increase in terms of their premiums. We know that, that there will be an exacerbation of financial instability for many of our providers, particularly our community health centers and our high public payer hospitals. That will happen as we lose coverage for many individuals that will that rely on that public payer coverage. And that, you know, the health safety net fund is an important backstop to that, but that is already being stretched thin. And the underlying growth in cost care is only going to make that more unsustainable in the future. And finally, we note that all of these dynamics will only exacerbate the existing disparities that we see in health outcomes based on a number on income, on race, and other dynamics. So noting these two crises of affordability and access, our main recommendation we put forward here is to enshrine what we heard at the cost trends hearing and to say this is the moment when we, as policymakers and stakeholders and leaders, need to recommit and convene and develop a consensus on a comprehensive set of reforms that's consistent with our principles and values of shared responsibility and, in this moment, shared sacrifice. If we can do this, we can once again be that national leader in reimagining our healthcare system. And as you said, Commissioner Walsh, in transforming and thinking about a bold transformation of our delivery system into one that delivers the outcomes that we value as a Commonwealth. Along with that call to action, the recommendation includes areas that through this work and past work, we think should be on the table in terms of thinking about how best to improve healthcare affordability. And that we recommend that as this group convenes and develops that consensus comprehensive approach, that these should be on the table to be addressed. And so we lay out 4 big areas. They're not to say that these are the only 4, but we tried to, per some of your suggestions, keep this focused this year. And so focused on the areas of administrative complexity, healthcare prices, pharmaceutical spending, and low value care or avoidable utilization, or what could otherwise be called kind of right care, right time, right place. In some of these areas, we note that there are different types of policy solutions that are being experimented on in different parts of the country. That there may be opportunities for new types of innovation, specifically around on the pharmacy space. We note here that we do have some new tools and new data that were provided through the new legislation, and that we think that the recommendations through OPA and the Division of Insurance can help guide what the next form of reforms might be most impactful in this space. But really to lay out some of these broad areas of priority. The recommendation concludes, and it's not shown on these slides, but if you look at the full text, with a statement that the Health Policy Commission stands ready to support and assist and to participate in these efforts. The Health Policy Commission cannot do these efforts alone. This will need to be a coalition working together, but that we can stand ready to be a part of it. And then it details some of the future work that we're committing to do through our new offices of OPA, the Office of Health Resource Planning, our Behavioral Health Workforce Center, and others. So we were able to share this with you in advance. I will turn it over to you, Madam Chair, to facilitate a conversation on the proposed recommendation and approach for this year's report.
Thank you, David. Questions or comments or thoughts from commissioners about the report and the recommendation?
Yeah, let me maybe offer a couple of thoughts. So first of all, I think this is really well laid out, the right target areas. I am struck by the comment Commissioner Walsh made about the transformation of delivery system, and I think that's spot on. And I want to come back to that, and then I'm going to sort of meander a bit just before I get there. I was struck by this particular focus on prior authorization under administrative complexity. I know we went through several iterations around it. And, I probably ought to remind ourselves that there's been studies done. Milliman did a study that showed that in the absence of prior auth, premiums could go up nationally around 5%, Massachusetts even higher than that. And prior authorization to me is just a symptom, actually, of a delivery system that is not working correctly. If you add and by that, what I mean is, I got my start in the healthcare business at Kaiser Permanente in California. And by no means do I say they're the best system, but it's a system that's built to serve our population. You start by saying how many members you're going to serve. What's the right ratio of specialists to primary care physicians? What's the right ratio of primary care physicians to physician extenders? How many hospital beds do you need? How many, and it's beautifully laid out. And in a world like that, prior authorization does not exist. I worked at Kaiser, there was no prior auth. And that's the world you want to evolve to. The problem is we're not there. And then you remove a blunt instrument like prior auth out, all it's going to do is increase premiums, guaranteed. And not only that, it creates an adverse side of it, which is, I remember a conversation with a chief of a large medical group in Massachusetts who said to me, hey, if you take that out, you're going to take away one of the tools we have of oversight we have around whether our clinicians are practicing clinical to the clinical protocols that we want them to practice to, right? That's what you're doing. So we need to be very careful about the words we use. My personal view is we should be taking that phrase out. It's completely okay to talk about, improving, not impeding care for patients, completely perfect. Now, and then you look at where prior auth is going, right? I mean, next year with original Medicare, CMS plans to start prior auth on 17 Part B services. And why are they doing that? Because they think there's overuse. And which goes to number 4 here. We're talking about low value care. The whole point of prior auth is, again, just to make sure care is being delivered based on existing clinical protocol. So my sort of long diatribe around got to be careful about what the words we use. I do think there's an opportunity to include something like what Commissioner wants to say, which is these are all good tactics, wonderful to do those, but you got to get at core delivery system reform. And we ought to give some thought to maybe including a couple sentences around that. Fundamentally long-term, the state needs to consider getting even more hands-on with delivery system planning. Those are my comments.
Thank you.
I'd like to add on to that, which was very well said, that, prior authorization is really just one piece of a very complicated puzzle, right? I think, there's so much more that could be called out in this recommendation that contribute to the wide variation in prices we see across the system, that contribute to administrative burden, that contribute to fragmentation of care and providers not being able to communicate with one another. And those include, one, the fact that we have at any given moment hundreds of different contracts that different payers make with providers that result in a different sort of fee schedule or set of negotiations and prices, you know, that's one huge piece of administrative complexity. We also have, you know, a lack of, you know, interoperability of certain electronic medical record systems where, you know, if a patient is seen in a certain community health center or other outpatient setting or preventive care setting, and they need acute care, at times, you know, the hospital that they end up at is not able to know anything about their history or their records. And this is clearly something that threatens quality of care. So I think while prior authorization is certainly a priority to address, I think we should also keep our attention on some of the other contributors to administrative complexity that are clearly a part of the story. And, you know, it's daunting, but I don't think we should leave those out of the conversation at all.
Just to respond, I think it's, if commissioners, I think it's helpful to bring up the full text of these recommendations, because I think on this one, the full text of this recommendation is all around the broader sense of administrative complexity in the system. And it's really just at the last sentence that we say, e.g. prior authorization. So I don't take that this recommendation is solely focused on prior authorization in any way. And that's not the intent. And as suggested in this recommendation, some of the strategies to reduce to this burden may be around automation. Maybe around, so that may not mean elimination. So I think there was an attempt here to recognize that there may be different strategies to address administrative complexity.
Just maybe just a counter to that is we're starting off with talking about known drivers of healthcare costs, right? But there's evidence, at least if you believe the Millman report, that says prior auth actually reduces costs. So my point isn't necessarily whether prior auth should be there or not. That's not my point. My point simply is when you make, and when you just point out at one example, that's a problem. That feels to me like we're advocating for prior auth being taken out, which is not what we should be doing. I'd rather us take that off, or to what you were saying, add other examples.
Yeah.
With that.
Yeah, I think hearing your point, which is that for any change for an administrative complexity, you always look at, is the complexity worth the benefit that patients and the system receive from that complexity? And with that as the focus, evaluating any aspect of administrative complexity, including prior auth,
Absolutely.
which has become a very, important touch phrase, I think, with the provider community, to at least consider whether there's any simplification for prior auth, because we really are at the point where providers are deciding that it isn't worth it to them to practice because of the amount of time that they have to spend on administrative tasks that they perceive to have no value. And what I can say, having worked, for decades in healthcare, is I have never heard a physician or any other clinical provider an administrative act that they understood the value of, including things that I dreamed up in a health plan that might look on the surface that they were tremendously administratively complex. But if the providers can understand it and understand the value of it, that it's either preventing an unnecessary or low value care or poor quality care. So I think framing this in the context that administrative complexity is a very important area, but we don't want to lose any benefit from the administrative checks and balances that are in place within provider systems and with health plans. I'm not hearing any commissioner disagree with that. It's just, let's avoid confusion about an all or nothing approach to one lever. And I see your point on that. But I think we're all saying administrative complexity as a focus is important and is, and I like the fact that we're identifying areas of focus this year, because we're also all agreeing that there needs to be some broader discussion about how to approach each of these areas. So we don't want to get too specific. And I think that was very well done by by the team.
And Commissioner DeVoe, just to add to that, as we anticipate sort of a deluge of redeterminations for Medicaid happening with more frequency, this sort of reduction in administrative complexity is all the more important. And I think, the on-the-ground work that Healthcare for All has done in really trying to kind of get out there and help folks along that process is important. But I also think that their work would be a lot easier if we're able to really substantially reduce administrative complexity. So it's definitely all the more important reason to have this policy recommendation probably as the first one.
And I don't know that we intended that to mean that it was priority number one, but certainly when I saw it as the first one, I had the same reaction. I felt like that was an important highlight. What
I'll
else?
say that.
Oh, Commissioner Erickson and then Commissioner Wall.
The themes seem important, right? Like that we cover administrative complexity, and I mean the details of each of these themes are, that's where the devil is. And so like, what should we do about prior authorization or any particular administrative thing? I think that takes a lot of study. That's why we have a great team here and further reflection. But like, is that something we should be thinking about? Yes, right. And healthcare prices, low value care and pharma spending, those are key issues that face for us. I think the other one that I didn't see, because I guess we just did it in some sense, is thinking about private equity and the kind of organizational form. And so we're still getting our feet wet on that one. But those would be big themes that I've been thinking about. So these look good.
Yeah, I think that's a very useful way of framing the discussion. Is there any disagreement about these themes and whether these are the ones we should be putting forward as the biggest priorities? And are there any that we're missing? I think that's a very helpful way to think about it. Anything that we aren't recommending here that we think is important, because I do feel that by focusing on a fewer number of areas of focus, we're more likely to, however this moves forward, we're more likely to get results in action. Commissioner Wall?
Thank you, Chair. The points on specific words, I think are well-meaning and well taken. I think the challenge in healthcare is that there are terms of art that people come to know, and they might be broader than they think. And so when we think about, nobody can really give the elevator pitch on what 340B is, right? Or surprise billing, or site neutrality, or prior authorization. But they all could in times be barriers to patients getting care. And I think that any of us could go through the 4 recommendations and we could wordsmith things in or out based on our own experience or our family experience or our professional experience. And so I looked at them with Executive Director Selt as a package. And although they all aren't perfect, in my own personal opinion, the overarching recommendation that's on the screen is, and allows broad latitude in a time of uncertainty and change to look at all of these areas. And so although there are things that given the power of the pen, I might change individually, collectively, I think we could all appreciate and agree in the goal and move forward as written.
Commissioner Wall?
So I think I'd be remiss in not diving in a little bit to the details of the low value and avoidable utilization topic. And just to, remind commissioners, it's stated in here that part of that needs to be continued support and investment in the Massachusetts healthcare workforce. And I think that's critical, and it's somewhat counterintuitive. We need to spend more, we need to invest more. It goes along the lines of what the primary care task force work that they're doing, where we need to be supporting, investing, growing, spending in areas that provide high value, and that prevent and help to prevent the overuse of low value care. And that's particularly important, I think, in the home care space, where I do a lot of work. and doesn't interact on a policy level. There's really a divide, I think, between long-term care and acute care. But they're obviously connected. And as we see a growing population, as people with severe disabilities are able to live longer, thank God, with proper care, and people are able to live at home and avoid going into costly institutions, nursing homes, group homes, other things that are more expensive. I think we just need to continue to focus on that and continue to estimate what our growing needs are going to be and make sure that we're meeting that. If not, we're going to be going backwards in that front, and we're going to be seeing more and more people who are unable to get the chronic care or long-term care that they need from high-value providers and end up in ERs, nursing homes, and other lower value care settings. So just want to reemphasize that as we're, taking a big picture look, which I think is crucial. That's got to remain sort of a focus of ours, is the need to make sure we have the workforce that we need in the areas that we need, and that we use those supports and investments to lower the overall cost growth of healthcare, which is the overall mission.
Commissioner Mahoney?
Yes, thank you. And thank you for the opportunity for this discussion and for me to listen and learn what my fellow commissioners are thinking. I think following up with Commissioner Wilmoth sort of taking a step back, one thing that part of I was thinking, like, what does this something like the hearing for the health care cost trend do? Part of it is that it's framing the discussion, like it's preparing the public, it's sending out a message. And I think the message was certainly that the system is no longer, whatever system we have, it's no longer capable of self-regulation and delivering all that results that we would want, including low cost sharing, higher quality, lower premiums, better workforce pay, right? That the system is not able to deliver that on its own. So it requires us to have some type of convening where all the stakeholders come in and essentially all sacrifice something in order for us to get to the other side. And I think the point I'm trying to make now is that it's entirely possible that there's so much waste in the system that we can get to the other side and everybody is better off and everybody has more, right? It's entirely possible, but it's also possible, and I think this is where I took Kevin Tabb's comment. It's entirely possible that as a polity, as a community, we have to be ready that there are things that we have in today's system that we will not have in tomorrow's system if we have an entirely rational and entirely better designed system.
Yep.
Somebody's waste is somebody else's salary, right? Like it's sort of, and so I think part of my comment is that I think I want us to be cognizant and to send a message out that it is possible that a better system could mean less of something, right? And I think we have to be ready. I don't think we should promise. I think we made that mistake with the COVID vaccine, right? We promised that one COVID vaccine will make you immortal, right? Like that was sort of like our promise in the midst of the epidemic. And I think we have to make sure we don't promise that we are simply going to make everything better for everybody in every case, right? Like that there's going to be no sacrifice involved. There's going to be sacrifice involved. And that's the part where I'm not sure that we've prepared the greater public that in order for us to spend less, well, we have to spend less, right? Like, so that will have an impact.
Yeah, I think that's a very important point. Rationalizing the system overall means that there will be some adds and some things that are subtracted. I also felt Dr. Tabb's point was it's very difficult for any individual to do that on their own. And I felt like that was a really important comment. And leading back to the role for both government and specifically also for the HPC doing health planning. Because in that rationalization, for one system to try to make changes is both a challenge for the communities that they serve and also for them in the market. So I think that's a very important point. Yes, Commissioner.
So-
Harrison?
I will say I am in favor of adopting these as written. And as I look at this, I think of the kind of baseline assumptions we bring in. We focused on affordable, accessible, equitable care, all valuable things. One thing we assume is that we'll have high quality care, and we do, and we wouldn't want to lose sight of that. So I'll just note that is an assumption that's coming in, and that's not guaranteed depending on what kind of, you could deliver low quality, low cost care, but I'm not sure that that's what we are looking for. So.
Good point. That's reflections and, yes.
Yeah, I also support as written, and I think the key emphasis for me that comes through is this is a scalpel, it's not a sledgehammer. And there's an emphasis, I think, to HPC's strength, which is leveraging data, information, transparent disclosure of information to ensure that they're getting this right. So to me, I support all four of this as written.
As the beginning of a, now our input to a broader discussion.
Commissioner DeVoe, if I may, again, just to touch on the second recommendation on healthcare prices, I want to just make sure, because as it's stated, it seems to refer to the prices of healthcare services, but does it at all refer to the prices of insurance premiums, or maybe sort of the rate of cost sharing that patients face? Because that was such a significant focus of the cost trends report this year. And I think it's an area of increasing concern across the board. And I think as a health system, the WHO says that financial risk protection is an important and essential part of a well-functioning health system.
Yeah.
And I think,
I mean,
is that part of it?
I didn't read that specifically to be part of this area of focus. This was really more around the major driver of healthcare costs, which was the prices as an input then to insurance premiums. But what I think, if I'm understanding you, what you're saying is cost sharing as a decision by employers in terms of setting co-pays, deductibles, and cost sharing is another aspect of healthcare price. Is that?
Well, more like the prices of insurance, the prices that patients or individuals, families pay to be insured, to access care.
Yeah.
Is that, because that's a
So
significant
this is more
driver of-
input into that.
Okay, all right. So those aren't necessarily.
Driver of the premium cost. And that's why the focus is on this as the major driver of
Yeah.
premium cost. But
I mean, I think that's the argument that insurers would make, that that's the principal driver of the premium increase, but I think it's a part of it. No?
well, it's, yeah, it's a part of it, but it is an actionable part that is a major part. That and pharmaceutical prices, so. Right, and administrative complexity, so it's kind of, yeah, breaking it down into individual components.
I'll just add, Dr. McGregor, what's not included in this particular chapter and section, but is included in the report overall, is we did have 2 chapters on cost sharing. And included within each of those chapters was a set of targeted recommendations that were really specific that could be taken to what we had seen as the unpredictability of deductibles and a more consumer some changes that could be made to cost sharing benefit design that would make for more predictability of cost sharing. We had some thoughts around financial assistance programs as well. So those are a little bit more kind of in the targeted realm around cost sharing and benefit design that were re-embedded within next to those chapters.
Saw that.
So
In the introduction to the recommendation also includes some language around the
Yeah.
cost sharing.
It does,
Yeah.
it does. Okay. All right, well,
Mayor, are you?
it's kind of
like-
implied is what we're saying.
Yeah, it's not in the areas of focus as is.
Okay.
If you feel like that rises to the level where it should be, we should talk about it a little more. But there were, I think, I think there were several other areas that we could have potentially
Of course.
chosen. I mean, one of the things we've gotten as feedback in the past is when we have, right, too many, when we have 8 to 10, it seemed like we lost the
Mhm.
sense of,
Mhm.
momentum to get something done. But we also left some things that we felt were very important. So it's
Of
a
course.
balance, but
Of course, yeah. Well, as long as it's, it's on the record that it's implied and it's a priority, I
Yes.
think that's important. Good.
Madam
So-
Chair, could I move that we accept the report and its recommendations as written?
thank you.
Second?
And let's move to the vote. And what we're doing is voting to approve the issuance of the report, really as as the output of the HPC, understanding that there are differences of opinion about some of the issues within the report, which I think is healthy. So with that, let me call for the vote. All in favor? Aye. Any opposed? Okay. Good, thank you. And now, we're going to turn to a discussion of 2025 state health policy action. Taken over this past year around the country. I'll turn it over to Director Selks to lead that.
Thank you, Madam Chair, and thank you, Commissioners, for that great discussion and really a blueprint for the work ahead. So in past meetings, Commissioners have expressed an interest in understanding a little bit more about what some of the other states across the country are doing in terms of some of their activities. And so as this is the kind of the last meeting of the calendar year, for the kind of the remainder of this meeting, you're going to hear a little bit of kind of wrap up for calendar year 2025. So I wanted to take you on a quick tour around the country to provide an update to you on some of the different activities that have happened across this country. And as I do so, I want to be very clear and give a very clear disclaimer as I talk through these different proposals, which is to say, this is not to say that these are recommended proposals by the HPC, that these are the correct approaches. As often when I go and talk to other states about what Massachusetts is doing, I always say the disclaimer, every state is different, every healthcare system in every state is different, and you always need to think about how you might tailor or adapt and think about whether different approaches may be appropriate or not. So this is not an endorsement, but really just responsive to questions about what is happening in other places. And again, might spark some interest conversation. So first, I did want to start to our neighbor to our south, and did want to reflect a little bit on the conversation we were just having. As Chair DeVoe said, there has been a growing national interest in thinking about prior authorization. As she said, I think a lot of this is being motivated by a sense of the administrative time that is going into a primary care clinicians and other clinicians day that is being spent on administrative tasks versus clinical care. And so there was 2 states this year that did pass pretty significant legislation on prior authorization. In September, Rhode Island passed legislation authorizing a 3-year pilot program, which would prohibit using prior authorization on services ordered by a primary care provider. Importantly, prescription drugs were excluded from this pilot program. This is for the fully insured market, but the Office of Health Insurance Commissioner in Rhode Island did encourage that the health plans extend this to the self-insured market. California and Governor Newsom signed a law in October that took a different approach to limiting the use of prior authorization for certain services. Here, it's really tacked to an analysis of health plans and their approval rates of prior authors of services, and where the services had an approval rate above 90%, health plans would then be prohibited from imposing those prior authorizations. There is a reapply to then be able to reimpose, but that will be effective January 1st, 2028. The law also had some provisions around expediting the processing of prior authorizations and having more transparency and use of prior authorizations. So an interesting emerging field in the states. As we move north from California, or actually let's staying with California, their Office of Healthcare Affordability, which is an office that was established a few years ago, similar to the Health Policy Commission, it oversees their healthcare cost growth benchmark. They have taken a different approach and have broader authority in their benchmarking process to be able to establish differential benchmark standards. And so earlier this year, they defined what they call a high-cost hospital. And there is a methodology that's included here for defining such a hospital, and then put in place a lower spending target for hospitals that are so designated as a high-cost hospital, different from the statewide target. So in this case, they're attempting to do a differential target based on kind of the high cost evaluation of these hospitals. I would note the California Hospital Association is challenging OHIC, the Office of Healthcare Affordability, in their methodology and the imposition of this high cost hospital. So something we'll be paying attention to. Moving north from California, again, one of our other benchmark states, Oregon, they have been implementing their benchmark for many years. And this is the first year that they, per their law, had the authorization to impose a performance improvement plan, much like the Health Policy Commission. So earlier, just this fall, they announced that they are requiring 3 performance improvement plans. St. Charles Health System is a health system out of Bend, Oregon. Pacific Source is a commercial health plan, and United Healthcare, a nationwide health plan targeted for their Medicare Advantage book of business. So each of these plans will be required to file a performance improvement plan by January, and then we'll be able to required to implement those plans. So we'll be watching closely to see what these organizations propose and the ongoing implementation of these performance improvement plans. We will no longer be the only state that has had a performance improvement plan. Moving north, Washington passed legislation earlier this year that is joining their neighbor to the south, Oregon, in establishing limits for certain prices in their state employee program. Oregon has had this type of a policy in place since 2017. So Washington is also establishing a similar type of proposal that would establish certain caps on certain inpatient and outpatient services at a percentage of Medicare. I think interesting to me, at least, was this was paired with a reimbursement floor for primary care and outpatient behavioral health services. So was also tempting to provide additional funding to some of these services. And so this, I believe, goes into effect 2027. So we'll have some time, but we'll be watching this as well. Moving to the middle of the country, Indiana, state that has taken some interesting health policy steps in recent years. Really inspired by a very vocal business community, which has been motivated the legislature to take action. So one interesting proposal that did pass and was signed into law by the governor would set some limits on hospital pricing equal to the average inpatient and outpatient prices of the statewide hospital average. That will be effective in 3 years, or actually longer than that, January 30th, 2029. And if hospitals are not at that level by that point, there are penalties that may include the revocation of their nonprofit status. They also did some interesting legislation, specifically in the pharmaceutical space, and included some greater transparency on pharmacy benefit managers, and effective January 1st, prohibited PBMs from steering patients to their own mail order affiliated pharmacies, and are taking further action in the PBM space. Sticking on the theme of pharmaceutical, 2 different states had some interesting updates this year. The first is Colorado. Colorado was the first state to establish a prescription drug affordability board, or a PDAB, back in 2021. And this year established their first upper payment limit, which is a limit for which the health plans can reimburse for a prescription drug in that state, for Enbrel. And that was announced in, I think, October. And you can see here the upper payment limit that was established. That upper payment limit is equal to the Medicare fair pricing limit that the Medicare program negotiated. So interesting that they pegged it to that. I believe Amgen is the manufacturer of this particular drug. They are also in litigation. There has been a long history of litigation on this program, and so we'll watch this as well. And then a different approach is Virginia, which had their Save Local Pharmacies Act signed into law earlier this year. And they were really focused on efficiencies through PBMs. And so they were really looking to get some efficiencies by having a single state contracted PBM through their Medicaid program, and requiring that PBM have a fiduciary responsibility to the state, pass through 100% of their rebates, and have very high transparency and full disclosure of things, and a prohibition on spread pricing. So an interesting approach from Virginia. And then finally, bringing us all the way back up into New England, Connecticut also had a very comprehensive reform in the mostly focused on the PBM as well, and a very comprehensive set of reforms. One requiring PBMs, again, to uphold the duty of good faith, disclose any conflict of interests, mandate that PBMs offer their plan sponsors at least one plan without spread pricing, enhancing the financial reporting of PBMs and their mail order pharmacies. They also are beginning explorations of in-state manufacturing and Canadian importation. And those are obviously at very early stages. And finally had a proposal around limiting price increases for generic drugs to the rate of inflation. My understanding, I think, is that is also being currently challenged. So a wide range of different activities across the country. We will continue to watch these, and we'll provide updates. Happy to take any questions from commissioners on any of these activities.
I'll make a comment. Oh,
Please, or comment.
the comment is that there are some interesting ideas here, but I'll echo a theme that came up at the cost trends hearing. Is I'm glad I live in Massachusetts.
How, this is not really directly about this, but how, so like I'm in contact with all the other secretaries every 2 weeks. We have a formal meeting. Do you have the same kind of thing where you're meeting with people from Oregon and California? It's on a semi-regular, non-topic specific basis, just.
Yes, it's been, I participate in the National Academy of State Health Policy, NASHP, which is a great forum for people in both kind of government agencies, Medicaid agencies, health agencies that, are focused on cost containment and oversight agencies. And we are in contact regularly on these types of updates. The Milbank Foundation has also supported a collaborative among the states that have the benchmark programs to be able to share lessons learned, and share information and data and different approaches. So it's I think a really valuable thing to be able to learn and to at least understand what's happening in different states. And we'll continue to bring this information to all of you.
Hey, David, with respect to California's prior auth legislation, is that also only for fully insured, or did they extend that to self-insured?
I'm not 100%, but I just given what I know about ERISA, I'd have to assume it's just for the fully insured.
You know, and I'm just gonna say, my 40 years of health plan experience, I can't recall even one employer saying, stop with prior auth. So obviously they see some value in it. So, enough said.
So, Madam Chair, if it's all right, we're going to move right into the Executive Director's report. And we have just a few last agenda items for the public portion of our meeting today. Up first is our regular update on material change notices. And I'll hand it over to Kate.
Great, thank you, David. You all know this slide well by now. So this summarizes all of the material change notices we've received to date. Since 2013, at this point, we have now reviewed 198 market changes. We've only almost made it to that magic 200 number. Of these, transactions involving mergers, acquisitions, or contracting network affiliations for physician groups remain the most frequent, followed by the formation of contracting entities. And I did want to note that the second from the bottom category there, we now have received 3 different notices reflecting our new authority that wouldn't have otherwise been received regarding changes in ownership or control involving private equity companies. On the next slide, just a reminder. On the next slide. Just a reminder that we have 2 different cost and market impact reviews currently in progress. We are reviewing the impacts of the merger of Beth Israel and Lahey, and we are also reviewing the proposed contracting affiliation between Minute Clinic Primary Care and Mass General Brigham. Since our last board meeting, the HPC has closed its review of 4 different transactions without recommending a cost and market impact review. First, a proposed joint venture between Milford Regional Medical Center, which is part of the UMass Memorial Healthcare System, and Shields Healthcare Group. That joint venture would own and operate MRI and PET-CT services at Milford. And in our preliminary examination, we found limited potential for increases in spending as a result of the transaction, and that any increase would be expected to be driven by an increase in capacity or expanded service offerings, as there is some expectation for improved scan efficiency and changes in scheduling. However, the total amount of the potential increase would be limited by the relatively small scale of the service at Milford. The transaction does have the availability also to increase the availability of MRI and PET-CT capacity in that location. And we did not find any evidence that this was likely to negatively impact clinical quality. The second transaction highlighted here was the proposed acquisition of the parent entity of AmSurg, which is a private equity-backed owner and operator of over 245 ambulatory surgery centers across the country, including 9 in Massachusetts, by Ascension Health Alliance, which is a national nonprofit health system and one of the largest Catholic health systems in the country. In our preliminary examination, we found limited potential for impacts to cost and market functioning in Massachusetts here as well. Ascension does not currently have a Massachusetts presence, limiting the potential impacts on market leverage from this acquisition or changes to referral patterns. And we did not review evidence suggesting a negative impact on quality or access. The parties did state that Ascension intends to maintain the existing AmSurg sites and services in Massachusetts. Third, we reviewed the proposed acquisition of CabaFusion Inc., which is a national specialty home infusion services company with locations in Massachusetts, a newly formed subsidiary of Nautic Partners, a private equity firm. And in our preliminary examination, we found limited potential here too for increased spending in Massachusetts. Caba Fusion's commercial prices, based on our analysis of the APCD, for home infusion drugs are similar to that of its largest competitors. And Nautic does not own other home infusion providers in Massachusetts, making it unlikely that this transaction would increase Caba Fusion's bargaining leverage and materially change its pricing. We did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. And then I did want to flag that pursuant to the HPC's new authority to require the submission of post-transaction information, we have required that Caba Fusion and Nautic provide information to the HPC in the event that Nautic later sells its interest in Caba Fusion, if the transaction is not otherwise subject to our review, and to provide notice to us if Caba Fusion files for bankruptcy at any point. Number 4, we reviewed the proposed acquisition of select physicians and locations of St. Vincent Physician Services, which is a multi-specialty physician group in central Massachusetts owned by the for-profit Tenet Healthcare System, by Healthy U Family Medicine, which operates clinics providing primary and specialty care in California and Arizona. Healthy U is owned by private equity firm BIGH Capital Holdings, and under the proposed transaction, 4 different St. Vincent Physician Services practice locations with 12 physicians, nearly all primary care providers, and 5 nurse practitioners would transition to Healthy U. In our preliminary examination, we found limited potential for the transaction to negatively impact spending and market dynamics in Massachusetts. Healthy U does not currently contract on behalf of other Massachusetts providers, and limiting the potential for increased market leverage that would change commercial pricing. And we did not review evidence indicating that the transaction is likely to negatively impact clinical quality or access to care. Yes.
Question on
Yeah.
how we approach these kind of analyses. So one
Mhm.
is, okay, we have a change in ownership, it increases bargaining power, that increases prices, that increases spending. But we've seen, like, say, if we looked at Stewart and how did that impact spending in the Commonwealth? It removed actually competition from the market by basically running hospitals under, extracting assets. Is that something that we could imagine going on with this transaction? Is that something we could, or anticipating as a potential outcome and modeling that's impact on potential spending? So I know it's a big question. It's not like a standard methods question, but I think.
Yes, yes. So in terms of our pricing analyses, a lot of those are involving dynamics in terms of bargaining leverage and payer contracting practices. However, you are absolutely right that there are other activities that private equity has absolutely been associated with that are often destabilizing to organizations, have impacts on costs, quality, and access that may not be that same type of pricing dynamic. That is the type of thing that we try to dig into pretty deeply in the back and forth that we engage in with the parties. So as a part of all of our transaction reviews, we get all of the underlying agreements. We interview the parties. We send requests for detailed information. And we do a number of analyses that are really driven by the facts of that transaction. And so where we identify specific risks, we do ask for certain commitments or ask for more information to try to dive into those. And I will be candid that a lot of that is fact-driven and is different from one transaction to the next. So for this particular one, we asked the parties to consent to, and I will actually say publicly what they consented to us disclosing as part of their public commitment with regard to this transaction. And I do want to reiterate that we do have this ability to solicit additional information from them for 5 years. So we can solicit information if we see anything happening that is not commitment. But they have publicly committed to maintaining access for the current patient panel, including their MassHealth patients. They've committed to comply with applicable transparency and oversight laws in Massachusetts, including filing with the state's registration of provider organizations program, participating in the cost trends hearing if so requested, et cetera. And Healthy U has also offered a public commitment that it's committed to the long-term success of the portion of St. Vincent Physician Services that it acquired for the benefit of its clinicians, patients, and the community served, and that it does not intend to engage in any behaviors that destabilize these practices.
Just to follow up, because I've
Yeah.
been thinking a lot about real estate and like the severing of like the ownership of the hospital real estate from the actual hospital. It's not like there's another hospital campus they're gonna move to. So this is less concerning perhaps because it's these physician groups that you could imagine they move to other locations. And so that's not the concern here, but that would be something that would be reviewed in a future iteration if there were a kind of different set of facts.
Yes, absolutely. And actually, that's one of the new triggers for material change notices that was part of the new law, and that will be releasing regulations on soon, is that before engaging in significant transfers of assets, including real estate for the purposes of a real estate lease back, they have to provide notice to the HPC.
And also in your research on, I guess, the acquiring entity's previous business in California and Arizona, do you have data on the extent to which they raised prices or the extent to which they engaged in layoffs or kind of massive or rapid staff changes and turnover?
Yeah, so a lot of the information that we reviewed was provided to us confidentially, so I'm just going to provide high-level information. But the information that we reviewed was did not raise significant concerns that we needed to run down further than what I just described.
Okay, but they don't have any obligation to abide by keeping prices at a set level aside from the benchmark.
Correct.
Okay. All right. Thanks.
Any other questions? Oh, yes.
Kate, I have a sort of a different take on this. As I look at Milford and St. Vincent's, these are hospitals selling off assets. And we have seen that before. And I'm wondering sort of what and you know, obviously margins are low and cash is cash. I'm wondering what it tells us about the larger environment, and does it signal any other actions that we should be thinking about?
Yeah, that's a great question. So I do think that we have heard from a number of providers in many different aspects of our work, a need for capital. And so I think that is a thread running through many pieces of our work and work nationally, and is one of the main reasons cited for the growth of private equity in healthcare. It is certainly a trend that we are keeping a very close eye on. I will note with regard to the UMass transaction specifically, just to be clear about that, UMass actually has a very similar arrangement for Shields, with Shields at all of its other locations. So I think the Milford transaction was a little bit of a different motivation than that. Any other questions before I move on?
I'll just add one thing, Kate and commissioners. You know, I think there had been a request at a previous meeting and one that I do want to return to, which is to maybe zoom out a little bit and provide a little bit more of an analysis to you commissioners about what we've seen in terms of trends for the transaction, say over and with some of these trends. And I think that's something that we can work on and bring back to you and have a little bit more of a forest from the trees view than just this presentation, which we do at these meetings, which is always, you know, what do we have right in front of us? I think that would be helpful to maybe have some of the bigger picture conversations that we want to have. So quickly, Kate, what do we have before us right now?
And then the ones that we are currently still reviewing, we have 5 others. The proposed acquisition of Acton Medical Associates, which is a primary care practice with locations northwest of Boston, by Atrius, which, as you know, receives administrative and non-clinical support from Atrius MSO, which is owned by Optum Care, a subsidiary of United. Second, we have the proposed acquisition of Quality Life Lawrence, which is a licensed adult day health facility located in Lawrence, by Active Day, which is an adult day service and home care provider backed by private equity firm Audax Group, with 100 centers across 10 different states, including 7 in Massachusetts. Third, we're reviewing a proposed clinical affiliation between Dana-Farber Cancer Institute and Sturdy Memorial Hospital, in which Dana-Farber would operate a satellite ambulatory cancer clinic on Sturdy's campus. Fourth, we have a transaction involving a significant equity investor in which Suncrest Health Services, which is an owner of hospice, home health, and palliative care companies in 25 states, including Brighton Hospital, Massachusetts, Hospice, Massachusetts, sorry, would be acquired by Sun Comfort Parent, which is a Delaware limited partnership. And finally, a proposed joint venture between Sturdy Memorial Hospital and University Orthopedics, which is a physician-owned orthopedic specialty practice based in Rhode Island with some Massachusetts locations. And that joint venture would establish a freestanding ambulatory surgery center in Mansfield, Massachusetts. And we will be in touch as we develop findings on each of those transactions.
The holidays are canceled for Kate and her team as we review these transactions. Thank you, Kate.
Thank you.
And for our final updates, an end of year closeout, I'm very happy to turn it over to HPC Chief of Staff Hannah Klumach.
Good afternoon, commissioners. I recognize that I'm the last thing standing between you and a very quick break. So I'm going to keep this brief, but as it is our last board meeting of the calendar year, I get to share a highlight reel of some of the HPC's achievements in 2025, as well as announce a few new exciting opportunities coming in 2026. So to kick things off, I know everyone is familiar with this slide. We've shown it at, I think, almost every board meeting, but very excited to highlight moving the cost trends report into our released category, and also wanted to point out that we have a new issue of Data Points, which is our interactive web series using Tableau graphics, which kind of dives a little bit deeper into some of the cost sharing findings from this year's cost trends report. So that is also available on our website today. And then looking at the category for upcoming publications, we have a number of reports and legislative studies in the pipeline, but wanted to briefly shout out and highlight the first official publication coming from our new Behavioral Health Workforce Center, which is slated for early 2026, and that's an assessment of behavioral health commercial rates. There were a lot of studies included in the legislation for that center, and they've been working hard to kind of move that work forward. All right, so to no one's surprise, we love to do calculations and ring up all of our totals and look at our stats by the numbers here. So while there are quite a few of our 2025 by the numbers, I'm going to just touch on a few of them briefly. First, under public engagement, as a result of the historic healthcare legislation that was passed earlier this year, we have to shout out our 2 new offices, UPA and OHARP, and also the launch of 2 task forces in collaboration with our interagency partners. So our primary care task force, co-chaired by Secretary Mahania, and our maternal health task force, which Dr. McGregor has served as the HPC designee and co-chair for that task force alongside DPH. Both of those launched their first meetings in 2025 and are moving forward very quickly, getting all of the work done towards those deliverables. Under meetings and conferences, I will highlight that we convened 27 public meetings this year, at which we presented over 1,200 slides. I am not sure if that number is something that we should brag about or apologize to you for, but that is the number that we had for this year, and we'll see if we can maybe not top it, but meet that same level for 2026. For our cost trends hearing, which we talked a lot about earlier today, I just wanted to say that I think this is a new record for us. 1,600 views of the live stream this year, and that's in addition to all of the folks who were with us in the room, and almost 4,000 views of the hearing webpage looking at all of those materials and the testimony. So a lot of engagement with the cost trends hearing this year. Under partnerships, we're thrilled to highlight that in 2025, there were 65 patients enrolled in the HPC's Heart BP investment program. That is our program focused on addressing inequities in hypertensive disorders of pregnancy through remote blood pressure monitoring. There are 4 locations of that program, and they are all moving and working towards getting patients enrolled and serving patients through that program. As Kate just highlighted, a number of market oversight responsibilities, but we received 14 new material change notices, including 3 transactions involving private equity investors. And then to cap it off, I have to give a tremendous amount of credit and acknowledgement to our Office of Patient Protection. Our small but mighty OPP team fielded over 2,000 calls to the OPP hotline, reviewed almost 1,400 open enrollment waiver requests, and received 407 health insurance external review requests and 8 ACO RVPO external review requests. So that team is working around the clock supporting patients and supporting healthcare consumers. So a big year for the HPC, and we're very thrilled to be moving into 2026 with our new board. All right, so the HPC is preparing to launch the next term of our advisory council. First convened in 2013, our advisory council is comprised of leaders from across the healthcare continuum. The role of the advisory council is to support the HPC's numerous work streams by providing input on research agenda and policy initiatives, contributing feedback on the proposed investment priorities, and serving as a network for communicating the HPC's work to a broader public audience. For the 2026 to 2027 term, we are implementing a new process for welcoming members to the Advisory Council. As of today, we are opening up a web form for interested individuals to apply to join the HPC Advisory Council. We're very excited to see who applies and be able to introduce a brand new composition of the Advisory Council. The deadline for those applications is January 9th. And then applicants will be notified if they are selected. In the first quarter of 2026, we're slated for a meeting at that point. Any questions about the Advisory Council or the application process can be sent to a new designated email inbox, and that's hpc-ac@mass.gov. And then the link to the web form is at the bottom of the slide here. All right, our summer fellowship program. So each summer, the HPC welcomes a class of summer fellows to the agency for 10 weeks. This summer, we had our 11th cohort of fellows join us. We had 10 students who supported one of the HPC's departments or offices to complete a project over the course of the summer. I am excited to share that we have released our 2025 Summer Fellowship Program report that's available on the website, which features descriptions of all of the projects that summer fellows worked on over the summer, as well as their reflections of their time at the HPC. And then in tandem with that, we are opening the window for applications to our 2026 Summer Fellowship Program. So as of today, if you visit our careers page, there is an open position for summer fellows, and the window for that closes on January 20th. But please share this opportunity with any graduate students that you may know. It's one of our favorite parts of the year is welcoming all of our summer fellows into the agency starting at the beginning of the summer. And then my last update is that very quickly, we are finally releasing our public meeting calendar for 2026. So this calendar includes the HPC board meetings and the dates for the 2026 Healthcare Cost Growth Benchmark hearing and cost trends hearing. The meetings for our 2 task forces will be announced on more of a rolling basis, but those will be added to the calendar as they're announced. But this calendar is now up on our website, and we look forward to seeing everybody in 2026. That's it for me.
There's a conflict with any of those days. Should I let you know?
Yes, please.
Okay.
And one other important number from the year is 8, as in 8 new commissioners onboarded to the Health Policy Commission Board for a great year. We've accomplished so much, and I'm really looking forward to the work ahead. I'll turn it back over to you, Chair, to close out the public portion of our session.
So much, yeah, and we'll officially acknowledge that there are no new commissioners anymore. You're done with your first. Second. So before we adjourn from the public meeting, we need to take a vote to go into executive session. Do I have a motion? And a second? All in favor?
Aye.
It should be done by roll call. It should be done by roll call. Thank you. Well, just go around the room. Commissioner McCann,
Aye.
Commissioner Wilmoth,
Aye.
Commissioner Cotterill,
Aye.
Commissioner Wall,
Aye.
Commissioner Mahania,
Aye.
Commissioner Kaput.
Aye.
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 Commissioner Cohen.
Aye.
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 Okay. Thank you. We'll now adjourn the public meeting.